But considering the anatomy of the oral cavity, the roof of the mouth, because I'm aware that we have some other non-medical participants here, parents, guidance, and I will be as basic as possible so that I'll be able to carry everybody along. So the roof of the mouth is what we refer to as cleft palate. The anterior aspect of that roof of the mouth is the hard palate, as the way the picture is showing. The posterior aspect is the soft palate. And then the back of the throat, that's where we call the posterior pharyngeal wall. So you might hear me oftentimes saying hitting the posterior pharyngeal wall. So we go to what does it mean to say an individual has a cleft palate? The first thing is that the individual has to be born with it. It's a congenital anomaly. And the cleft palate presents most of the time as a kind of defect. It may be obvious, it may not be obvious. There are different presentations of it. But basically, we do have the cleft of the primary palate. That means the cleft is in front. Or the secondary palate, that means the cleft is at the back. And even when it's affecting the cleft at the back, it may affect just part of it, like in number 1 picture I'm showing here, or it may affect the whole extent of it. That's the number 2 picture I'm showing here. And sometimes this cleft palate may not occur alone. It can occur involving all the way to the lip, like the number 3 picture I'm showing there. But the individual needs to be born with it because there are other factors, other mechanisms that can cause a defect in the palate, and that is not cleft palate. So for a cleft palate, the individual needs to be born with it, and there are different presentations of the defect. And I will wonder, how does this affect the production of speech? I would use the door metaphor to explain it. Let's imagine the palate as a door that is separating the nasal cavity, that's the room upstairs, from the oral cavity, that's the room downstairs. Now, for the production of sounds, there are some sounds that are referred to as the high pressure sounds. Those are the sounds that are challenged in cleft palate anomaly. It's not all sounds. For instance, nasal sounds can be made conveniently by individuals with cleft palate anomaly. And the low pressure sounds, yes, can somewhat be made to some degree by individuals with cleft palate anomaly. But the most challenging of them all are the high pressure sounds. And this is because for these sounds to be produced, the soft palate needs to lift up, touch the posterior pharyngeal wall, and close up the nasal cavity so that air will be able to direct into the mouth, and then an explosive sound is made as the high pressure sounds. These high pressure sounds are the pa, the ba, the ta, ka, just like that. They are listed on the screen. So when there is a cleft palate, because there is a hole in the door, when the production of high pressure sounds are attempted, air escapes through this hole into the nose, and making sentences such as "buy baby a bib," which contains quite a number of high pressure sounds, will now come out as him. That's because a lot of air is coming through the nose, and they are unable to make the high pressure sounds like "buy baby a bib." Also, affected individuals may use other structures to make these sounds. And other structures, such as using the tongue to hit the and to make a statement like a cookie or a cake will become a cookie or a cake. That's because they are using the posterior aspect of the tongue to hit the posterior pharyngeal wall so that they'll be able to make that high pressure sounds. And some individuals would use their glottis, call them glottal stops. They'll use their glottis to make
okay, so look back to that.
So a statement like a cookie or a cake would become a ooey or a cake. A ooey or a cake. That's because they're using their glottis to make the sound. So these are compensatory errors because they cannot mount enough pressure. They cannot mount pressure in the oral cavity enough to make the explosive high pressure sounds. They use other structures like their posterior pharyngeal wall and the tongue, or they use their glottis to make the sounds called gluteal stops. So how do we treat this anomaly? Commonly, the treatment is surgery by having a palatal repair. Now, when the surgery will be done, how the surgery will be done, these specialties, they are specialist dependent and also center dependent. But the individual facilities, they have their protocol for managing cleft palate. But basically is to convert a large defect, a defect in the palate, as you can see on this screen, to this. And the soft palate should be repaired in such a way that it will be adequate enough to close the door between upstairs and downstairs adequately. So the possible outcomes that you can have following a palatal repair, it can be one, a good speech outcome. In this case, the soft palate is shutting up the nasal cavity adequately so that when the sounds are produced, it comes straight into the mouth. That's for the high pressure sounds. The soft palate is intact and there's no escape of air. Now, other possible outcomes can be a person it's possible it's short and therefore cannot contact the posterior pharyngeal wall. That therefore cannot contact the posterior pharyngeal wall. That is the defect is still persistent, though smaller, but it's still there. So air will still escape through the nose. Or after the repair, a breakdown of the repair has occurred. And this breakdown can happen in any part of the palate. It can happen at the back of the palate, where my cursor is. It can happen at the midsection of the palate. It can happen in front of the palate. And all these, which are called palatal fistulas post-repair, are areas where air can escape from the mouth during the production of high pressure sounds and go into the nose, causing nasal emissions. Now, another possible outcome is that the palate has been repaired and the repair is adequate, but the individual still continues to have a cleft speech. I will explain this by using the iPad metaphor. Imagine buying someone who has not used a laptop or an iPad before, a brand new iPad, lovely one, a good make. And then you expect the individual to just start using the iPad. The individual needs to be taught how to use the iPad. If not, the iPad will still be useless to such a person. Therefore, giving someone a new palate, they would need to be taught, especially if the repair has been done late, they will need to be taught how to use the palate. So that can be another reason why someone who has had a palatal repair may continue to have a cleft speech. So what's the role of speech therapy in all this? Speech therapy basically instructs a client how to use the appropriate structures to make sounds. That's to make the high pressure sounds. These sounds are made in different parts of the mouth, as the diagram is showing. We have the bilabials, which are made between the two lips, that's between the upper and the lower lips, like the pa. You need to put your lips together to make such a sound, pa, ba. Then we have the alveolar sounds, which are made with the tongue touching the alveolar ridge, that's the gum. And then you have it, you can try it even while I'm talking. You have the ta and the da. The tongue goes to meet the gum. And then you have the labiodental, where the teeth and the lips will have to come together to make sounds, such as the or we talk about the velar sounds. Those sounds, we have the tongue hitting the palate, as in ka, ga. So all that can be taught by different strategies, so many. strategies to an individual on how to make these sounds. But first, we should know that the commencement of the speech, before the commencement of the speech therapy, the sounds that an individual cannot make will need to be identified. These are the sounds that we call target sounds, because it's not all targets or all high pressure sounds that are, not all individuals may be able to make some target sounds while they may not be able to make others. And some, they may not be able to make any of the high pressure sounds. And some, it's just maybe a few. So they need to, an assessment session needs to be done whereby the target sound that a client cannot make will be identified before the commencement of a speech therapy. But then we should also know that speech therapy can start as early as when a child is still an infant. As soon as baby starts to babble. Of course, it will be difficult to say that, okay, tell a baby, put your lips together and do this. No. But when a baby starts to say ba, 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 or da, 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 a child that has a cleft palate will not be able to say that. So instead of encouraging such children, such infants to say da, 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 or you'll encourage them more to say the nasal equivalents of baba, like mama and baba. They are both bilabial production. But mama will be much easier for such a child to pronounce. And after palatal repair, speech therapy will be much easier because the placement, what we call placement of the sound, is already there. So instead of encouraging the child to say baba or dada, you encourage the child to say mama or nana or something like cookie. You encourage the child to say nuni. And this would eventually help the subsequent speech therapy that will be done after the repair. Now, for the speech therapy sessions themselves, that's for children now above the age of 3 years. Speech therapy can start 3 to 5 years if that's what's occurring at your own individual environment. But the therapy goes through a hierarchy, a speech hierarchy. And the first of that speech hierarchy is discrimination. The individual needs to be able to discriminate the wrong or the incorrect sound from the correct sound. We don't just jump into the therapy. The client needs to know that saying is different from ba. It needs to know that when he or she says is coming out from the nose and not the mouth. And he needs to know when it's coming out from the nose or when he's using compensatory sounds like glottal stop. The individual needs to know that. It is after the incorrect sound has been discriminated, then we can now move into the speech therapy proper. And we start by sound isolation. We need to teach the individual how to make the sound in isolation. There are several strategies for this. When the individual can now make a particular target sound in isolation, then we'll move to syllable. With making the sound in syllables, would then endeavor us to be able to teach how to make the sounds in words. Then we'll go to phrases and sentences, and then structured conversation, then eventually unstructured conversation. And we do this for each target sound, which will be taken one at a time. So that's how the speech therapy and speech hierarchy goes. We would need to note that speech therapy for cleft palate anomaly does not include oral motor exercises. And mainly because the reason why individuals with cleft anomaly speak the way they speak, if they are a straightforward cleft palate anomaly and not maybe a syndrome is associated or not. But the reason why they speak the way they speak is not because of a muscular weakness or neuronal deficits. It's because there is a structural insufficiency. So asking clients to go to do exercise such as balloon blowing, mouth blowing, twisting of the tongue, eventually they don't help. So we do not advocate that. And then we come to where these speech therapy sessions take place, where the speech room should be as welcoming as one can make it, as colorful as one can make it, as bright. And then to have loads of toys, animated pictures, coloring materials, where a child can feel comfortable in order to open up. Because when individuals, when children do not open up, they will not speak. And if they are not speaking, we can't even assess how they speak or be able to identify their target sounds. So the speech room should be welcoming enough that the child will always want to come back. And for personally, when a child has achieved a target sound production, it's usually a celebration, and the child goes in with a number of toys, which they, in our own practice, they keep as a collection. So things like that can be introduced into the speech therapy program, whereby it's more lively for the individual, and the child is eager to come back. Also during the sessions, the active involvement of whoever is accompanying the child is very important, because the success of a speech therapy session is grossly dependent on how much practice the child is done at home. I would want to say that the success is 10% dependent on what they get from their speech therapist and 90% on the practice that is done at home. So it is not acceptable, let's say a mother has accompanied the child to speech therapy sessions, and the mother is maybe in another room while the speech therapy session is going on, or the mother is on her phone while the speech, no. There has to be an active involvement of whosoever is accompanying the child. And also the person accompanying would need to be taught how to make these sounds as well. One should encourage them to make the sounds along with the therapist and the client while the session is going on, so that when at home, the exercise continues. The speech therapy sessions usually is different for each individual. The sessions will have to be individualized. Firstly, the target sounds can be different, and even the way they make their target sounds, their incorrect sounds, can be different. People learn at different paces, and we should also note that acquisition of sounds can also be age dependent. For instance, one would not start the speech therapy session for S sound with a 3 or a 4-year-old child, because it's possible the child may not be able to produce this. It's also possible the child can, but it's not what one would emphasize at the age of 3 to 4 years. And because people learn at different paces, the speech therapists will need to be patient with each individual. Some pick it up quite fast, and some you need to use like even 3 or 4 strategies for a single sound before the individual will be able to pronounce it. Now, it is also worthy of note that speech therapy may not or cannot correct a secondary cleft defect that is due to a structural deficiency. That's what we call the veropharyngeal insufficiency. Yes, one should, such an individual should still undergo speech therapy intensively. So, strategies such as correcting the placements can be done. That means instead of making the sounds with the compensatory structures like the glottis, instead of maybe saying B and saying B, instead of that, one can allow teach the child how to use it as bilabials, but it may still not sound adequate. For there to be an adequate production of the proper sound in such a scenario, a revision surgery will have to be done. So I would now, at this junction, want to show you the sample videos of a client of mine that had speech therapy done after palatal repair, about 5 years after his palatal repair. And the first one, I would want to note how the speech the cleft speech has affected him even from his perioral tissues psychologically. He tends to squeeze his nose together, squeeze his mouth together when producing these sounds. He was very cautious of the way he used to speak. So I asked him to count 1 to 3 at the beginning of the session, and this is a video recording of 1 to 10. Hello? Okay, I'm back now. You can hear me?
Internet went off.
Dr. Olusanya, go ahead. We can hear you.
All right, thank you. I'll play the pre-therapy video again so that we hear how. So after about 7 sessions, and he completed his speech therapy program, this is how he was able to recite the 1 to 10.
1 to 10. 1, 2, like that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, so what I want you to note also in this post therapy session is the way his perioral tissues are. He seemed more relaxed, he seemed happier, he was less guarded as per the way he was, unlike before. So
count 1 to 10.
At this junction, I want to give my acknowledgement first and foremost to Smile Train for giving us the opportunity to have speech therapy sessions for cleft palate anomaly in Nigeria. And I'm saying that wholeheartedly because before the advent of this intervention by Smile Train, we have been doing palatal repairs whereby we will now refer our patients for clefts for speech therapy. But they kept coming and saying that they're not having any form of improvement. And in fact, that was what actually directed my interest towards speech therapy, specifically for cleft. So Smile Train, we can't thank you enough for this venture. And then also I would like to thank Professor Crowley. She is our teacher, our Professor Ngozi. She's the Professor of Practice in the Communications Science and Disorders program.
No, se ofende.
Thank you so much, Adeola. That was a great presentation. Just to reiterate again, the chat room is open. If you could kindly share your questions there, we will take it from there. At the moment, we have 3 questions. The first question goes to our speaker, and the person is asking, what kind of material is used in filling the cleft that allows a lesion to possibly develop subsequently? And the second question is, how important is parental involvement necessary in case of therapy with children? And the last question I have here is, what can be done to children without cleft palate, but find it difficult to produce high pressure sounds?
Hello, NK.
Go ahead, you have the floor now to answer the questions.
First question, please, can you repeat that?
The first question says, what kind of material is used in filling the cleft that allows a lesion to possibly develop subsequently?
I'm not sure about what the person means by it. But yes, you can have prostheses as speech bulbs. They are made of acrylic, and then it can be made of several materials. Actually, it can be acrylic, it can be a form of elastic material. It varies. But what that does is to reduce the gap between the soft palate and the posterior pharyngeal wall, such that the residual palate soft palate can now close around it, thereby closing off the nasal cavity from the oral cavities. That's closing off the nose from the mouth, and then high pressure sounds can be made. So there are specialists who are involved in this. It's pretty technical, but there are things that can be done. Now, parental involvement, or should I say guardian involvement, because it's not in all cases that the parents are the ones who bring the children. So parental or guardian involvement is of utmost importance. If the parents are not involved in the therapy, it most probably would not work, because the therapy are more or less like instructional sessions and teaching the know-how. If these are not practiced, it will not work. It's like giving someone a prosthetic leg without any form of physiotherapy or how to use the prosthetic leg. The individual would have the prosthesis, but cannot use it. It will not work, except the individual practices, and how well the individual practices would show, would reflect on how well the individual can use the new palate, how well the individual can speak well. So it cannot be overemphasized. Now, the third question says, what can one do for children who have high pressure, who cannot make high pressure sounds and yet do not have a cleft palate? Now, cleft palatal defects may not be obvious. They may be occult. That means when an individual, or the unlearned eye, so to speak, or uninitiated eye, looks into the mouth, you might think that the palate is intact, but it is not. That's what's referred to as submucous cleft. So before one says that the child does not have a cleft palate, I think should be assessed by a specialist, so that I'll be able to rule out the possibility of a submucous cleft. Now, that's one. And two, it's also possible, not being able to produce high pressure sounds is not limited to cleft palate anomaly. It's also possible that the innervation of the structures that will be involved are not adequate. Neurological issues can cause that. And even in syndromic cases, yes, it can cause that. So the first thing is to diagnose properly what is wrong before we can now say that we want to institute treatment. Thank you, NK. Those are the 3 questions.
Yes, I think we still have a bit of time and more questions have come up. Thank you, Dr. Olusanya. Now, the other question we have is first thanking you for an insightful presentation, and is saying some of our palatal repair leads to shortened vellum. So in the event of persistent speech defects, can velar lengthening be a solution? That's one of the questions. And then the second question, I'm trying to group them in 3 so that you could address them sequentially like that. The second of it says, do you ever consider focusing on sounds best used culturally? Do you ever consider focusing on sounds best used culturally? And the third question says, do some patients with cleft lip only require any form of speech therapy? Do some patients with cleft lip only require any form of speech therapy?
All right, thank you, NK. Yeah, the first one is velar lengthening. Can it help for a palatal repair that has been done and the speech is still inadequate? Velar lengthening, in quotes, is one of the surgical interventions to treat a velopharyngeal insufficiency, that's a VPI, when the velum, that's a soft palate, is insufficient. So there are several techniques in order to ensure velar lengthening. Yes, the answer is yes. Velar lengthening is one of the techniques that can be used to treat VPI. Now, to consider culturally sensitive sounds, this we do practically all the time. When a patient presents for speech therapy, the speech therapy is done in the language that the patient is conversant with. And this is not because, okay, the modern individuals speak English. So therefore, no. You would engage the child one-on-one, be as friendly as possible. You would know the language that the child is conversant with. So in our locality, the Yoruba is the other language apart from English. But it doesn't mean that someone who is from a Yoruba-speaking home can converse with the public confidently in Yoruba. So if English is a confident language, then yes, we take the speech therapy in English. If Yoruba is a confident language, then the speech therapy will be done in English. And of course, the sounds will differ. But as I said earlier, individuals, the speech therapy is usually individualized. So the strategies that we have, or the tools that we have for the English one, we have the Yoruba counterpart. And I think this also goes even for my other colleagues in other different parts of the country. They have their corresponding materials in their local languages. So yes, the culture is considered. Now, the third one, that's can individual with cleft lip alone have a speech deficit? Yes, this can happen because cleft lip alone, in this case, I'm referring it to as cleft of the primary palate. That means where the alveolus is involved. And also it can happen where let's say the cleft lip has been repaired and the lip is short, cannot competently come together and form things like bilabial sounds like the ba or the pa. That may be a bit difficult. If the cleft lip involves the gum, the tongue going to hit the gum to make sounds like ta, da may also be difficult because there's a gap there. There's nothing to build the pressure at the back and then allow it to come out as a plosive sound. So yes, it can affect to some degree. So NK, those are the
the second 3 questions. Thank you so much. I still have a couple of questions, and I think we still have a bit of 4 minutes. Dr. Olusanya, could you help us address what is the role of group therapy? That is one question. And another one says, sometimes it's difficult for clients to redirect air emission from nasal to oral after cleft repair. What strategies can be used to produce these high pressure sounds? And another question is, what is the possible prognosis in speech therapy for acquired palate defects due to trauma or tumor resection?
Okay. Now, for the first one, group therapy, the main advantage with group therapy is that it's done, as the term says, in a group. So even shy children, you'll be able to get across to them faster, especially if you mix them with individuals who are not shy and they are making progress. So it helps with the peer involvement. That's the main advantage of group therapy. If it can be done and patients can be pulled together, then fine. And it also helps with resources. But when this cannot be done, individualized therapy can also do great jobs. Now for nasal emission, I think the question is what can be done when a patient has persistent nasal emission after palatal repair. Now, the nasal emission could be as a compensatory error. That means that the individual has a good palate, but is still used to that habit of passing air through the nose. Then in that case, speech therapy can help via several strategies. I can't go through all the strategies, but a simple one is to ask the individual to make the ha sound, that's to just encourage hair flow. That's through the mouth. And as the patient is getting comfortable with directing the air through the mouth, you now encourage the individual to close the lips on the airflow and then suddenly release. That would now allow the individual to know how it feels to produce the air through the mouth. But more commonly, it might be that the palatal, there's still a bit of velopharyngeal insufficiency. Even if there is, one should still do the speech therapy to an extent so that we'll be sure we have placement. And if after intensive speech therapy, you still have significant nasal emission, then the patient should be referred for a review for possible secondary surgery. Now for trauma, palatal defects following trauma, infections. Now these defects, they are different from the defects of cleft anomaly, and they can occur in any part of the oral cavity. So if prosthesis or surgical intervention can be done that these defects are closed, the speech therapy that will be involved in such may not be, if the adequate structures are there, may not be, should I say, serious enough as you can have for cleft palate anomaly, because the individual knew how to speak well even before the trauma and before the surgical resection. So what caused the speech defect was the defect, because a hole was created. As soon as the hole is plugged, it's usually easy, plus or minus speech therapy, to get back to normal. That's the last question.
Yeah, thank you so much. I think we'll try to wrap it up now. Maybe we'll just take 2 questions and then we'll open the floor for the president of SPAAN to briefly talk about the collaboration with Smile Train. And the last 2 questions I'm able to take now would be, have you already received a child associating cleft palate with speech or language delay? Then, which one do you rehabilitate first? And this other question says, what are the implications of late intervention?
Okay, so the first one, late intervention. The first one, yes, we have had some clients of ours who have language delays, usually from syndromic. What we are doing with such individuals is to go at their pace. We monitor their language development. That means that, for instance, when they come to clinic, we ask the mother, as the child starts making any sound, we don't make the therapy like age dependent. It's the individual that determines what we can do. So if the child has started conversing or has started making short phrases or even making single sounds, we ask what sounds have been made, and then we see how we can target the correction that we're doing. Then for late intervention, the main consequence of late intervention, one, I think, is the development of compensatory errors. When palatal repairs are done early, that is between the age of, before the age of 2 years, or at most before the child is between 4 and 6, when these repairs are done early and they are done adequately, they may not even require speech therapy, and they will just flow gently and gradually into normal speech. We've had individuals like that. But when speech palatal repairs are done after the age of like 12 years, it becomes increasingly difficult to correct the compensatory errors. Apart from that, this is, I don't have, this anecdotal, but I've noticed amongst older clients who are like 18 years, 20-something years, they have persistent nasal emission.
Hello, Dr. Adeola, are you still there? Hello, Dr. Adeola. I think we've lost her. Okay, while we wait for Dr. Olusanya to reconnect, could we invite Professor Julius Ademoyokoya, am I getting it right, sir? To briefly talk about the Smile Train collaboration with his organization, the Speech Pathologists and Audiologists Association in Nigeria. Over to you, sir.
Thank you very much. I'd like to start first by congratulating the Smile Train organization, as well as the SPAAN. I'm quite very happy this morning to see this development. And I believe this is a very good beginning of more wonderful things to come. So I like to congratulate Smile and SPAAN for this wonderful beginning. Second, I also like to congratulate our lecturer, Dr. Adeola Olusanya, for a very well prepared and well developed, well delivered paper. It has been very wonderful. Once again, I say congratulations. Now, talking about the MOU between the SPAAN. By the way, the SPAAN means the Speech Pathologists and Audiologists Association in Nigeria, as well as the Smile Train organization. This is another welcome development at this particular time. It's still an opportunity we have been waiting. And so when it presented itself, we welcomed it with 2 hands open. And I'd like to thank Kate, that's Dr. Kate Crowley. I'd like to thank Dr. Obi. I also like to thank Victoria for wonderful roles they have played. As we are all aware, Speech Pathologists and Audiologists Association in Nigeria is a body of professionals who are concerned with managing hearing and speech problems. And Why we are so particularly happy with this development is that the issue of cleft palate and lips, has been an area of interest to us, but then we've been having some challenges. So when the train came on board, it is like a divinely arranged, situation, and we really appreciate it all. The issue again that we also want to bring on board is that we believe this MOU is going to do a lot of things. SMILE and SPAAN, as I've mentioned, are on the mission to improve speech communication, language communication, and also to ameliorate the challenges, the adverse effects which cleft lip and palate, as well as other speech problems normally put on certain individuals. And having worked with SMILE, for almost 1 year now, because we've had series of meetings, also training, our members have also attended some of their training before the MOU was signed. We have been able to move from one stage to another. And we also hope that we continue to move higher and higher. Now, as I've mentioned, we believe that now, with more help coming from SMILE and also from other associations, which I believe that we also come on board as soon as possible, we are going to reach more individuals with cleft palate and lip, undertake necessary surgery. And also after the surgery, we also engage them in speech therapy. That is why I'm quite very happy with what Dr. Olusanya has touched on in her lecture. Wonderful things that have happened, but I also believe that's just, beginning. And we want to encourage, all individuals, different stakeholders. Let me use the word stakeholders because we are all involved in this multidisciplinary assignments. And we all have one target. We all have one mission to achieve. And the mission, of course, is helping these individuals to overcome their speech problems and also enjoy the benefit of speaking well, speaking fluently, speaking confidently, and speaking effectively. And we continue to give our best, do our best to support what SMILE Trail is doing. And also, like we mentioned, to also continue to extend our hands of fellowship, to different organizations which are also, doing one thing or the other in other areas. We hope that, we continue to beam the searchlight, reach onto them, bring advocacy to them, and also bring them together so that we can extend what we are doing now and doing it better, when we are united collectively. For now, I think, like I've mentioned, this is a wonderful beginning. And we also hope that, the trend will continue, just like we have seen, we have the timetable already. This program will be coming up every week. And we also hope that it will go beyond the, virtual learning, virtual lecture, to also give opportunity for so many people who may not be able to join us virtually, and also produce necessary impact, which we hope this MOU will produce. Once again, I'd like to congratulate, SPAAN. I'd like to congratulate the SMILE. I'd like to congratulate our lecturer, Dr. Adeola Olusanya. As I also like to congratulate everybody who has joined, this lecture, and those who will still join later. It's a wonderful beginning, and I appreciate this wonderful development. Thank you very much.